So the first one of all is venous anatomy. So whether you agree or not, so any intervention procedure, before starting, you should be a good knowledge about the anatomy. Without good knowledge about anatomy, I think it's really difficult. The more you do, the more issues it could be variants, it could be some abnormalities because of long-term use of catheters. So it's very essential to understand what is the safe access and how skillfully we can place this catheter. All this comes only by understanding the anatomy. So if you go to basics, probably the first year of medical schooling, where we start with anatomy. So you can divide the body into supradiaphragmatic, which is above the diaphragm, and infradiaphragmatic, which is below the diaphragm. If you closely look, the anatomy in a normal person is with no variants. You'll have veins in both the arms and in the necks, jugular veins and the subclavian vein. These two join together to form the innominate vein. The innominate vein join together to form the superior vena cava, and it drains into the right atrium. This is the normal anatomy in majority of the people that we come across. And the one specific thing that you see on the screen is cavo-atrial junction. This is very important, especially when placing a dialysis catheter placement. So we'll talk on this one more elaborately in the coming lectures. And the second one is infradiaphragmatic. It is the below the diaphragm. So the anatomy below the diaphragm is you have femoral veins. The femoral veins join together and form the inferior vena cava. The inferior vena cava is joined by the renal veins on the other side, and then it joins the right atrium. So this is the infradiaphragmatic venous anatomy. So how often do we see this normal anatomy? As I say, majority of the time you see normal anatomy, but there are always some variants. There's always some obstacles while dealing with this anatomy. So let's start with some variant anatomies, that congenital anatomy, or you could acquired anatomy. The first and foremost, which is very common, is a duplicated superior vena cava. So in duplicated superior vena cava, that means the patients have two superior vena cava, one on the right side, one on the left side. Sometimes they have a bridging vein, which is called the common innominate vein, but sometimes it's absent. So you should be very careful whether these patients has got variants and what type of variants this come across. So this is a chest X-ray, which is clearly demonstrating there are duplicated SVC, because on the screen you can see there are two catheters, one on the right side, one on the left side. If I show this X-ray to to randomly, people might say the left side catheter is in the wrong place. But if you know the real anatomy of this patient, then you can say, okay, this is a variant anatomy, and it's okay for the patient to have a catheter on that side. So you should be aware, keep an eye saying that is it normal or abnormal. The second one, sometimes we all know the SVC is on the right side. What if the patient has got SVC on the left side? You do come across, in my own experience, I could say a handful number of the times the patient does not have right SVC, it's a left SVC. So like in this case, if you don't know the anatomy, if you see a catheter being placed, first thing you'll be assuming and saying this is a wrong placement and the catheter has to come out. So always take a step back, look at the anatomy. Coming to the infradiaphragmatic, so you might have heard how the IVC is formed when the child is in the womb and everything. So one of the disruption of this is called interrupted IVC. Interrupted IVC, where there is no connection between the IVC and the right atrium. Instead, all the blood is draining from the collateral veins into the right atrium. This is called interrupted IVC. So especially the scenario is if you're trying to pass a wire from the groin and you are unable to pass a wire into the right atrium. So you should be thinking every time anything the wire is going in the wrong direction or something is not right, first thing you should always think is what is the anatomy of this patient. Next one. This one I think you'll definitely be coming across a dextrocardia. So where the heart, sometimes the liver, everything is interchanged. Instead of the right side, it's all in the left side. So this is a patient with a dextrocardia. So everything is flipped from right to left. So the catheter is placed. If I closely look at a chest X-ray, I'll clearly say this is a left-sided SVC or this is a mediastinal vein. But if you look at the anatomy of the prior chest X-rays and CT scans, you can clearly say this is a normal anatomy for this patient. Next one comes, this is a very rare. sometimes people have something called anomalous pulmonary venous drainage. Here, the pulmonary vein on the left side is draining into the brachiocephalic vein. As you can clearly see on the left side of the picture, you have a catheter where the tip is almost at the mid-lung. So this was clearly called as extravasation, and the catheter tip is being in the lung. So they asked the physician to take the catheter out. But when you closely look at the prior anatomy of this patient, the patient has anomalous venous drainage connection where the pulmonary vein was connected to the brachiocephalic vein. So this is a CT picture of the same patient demonstrating this is a variant anatomy for that patient. So next comes tetralogy of Fallot. So days are gone, like we probably these kids never grow up. That's why we never see them in an adult age. But with advanced cardiac techniques, they have a lot of surgical techniques where they do like pulmonary artery to pulmonary vein connections. So these patients live their life to full term like us. So one of the common scenarios is the IJV, the SVC is connected to the pulmonary artery. So sometimes the wire might be trickled from the IJV into the pulmonary artery. So keep an eye, is this some congenital anomaly which has been corrected? Next one, the very common scenario you come across is like, anatomy is one aspect. Sometimes looking at the picture, so you always say as a radiologist, you should look at the picture in two directions. If you don't see from the front, look from the side. So this is one of the scenarios. As you can see, the chest X-ray is filling the whole screen. This is a big patient with everything is shifted to the right side, but the patient was having normal anatomy. But the way the catheter is flowing, you should be aware, is this just a positional one? So on the second picture, you can see because of the position, the wire went into an ajagus vein. This is again like a collateral vein, but you should be aware the way the direction of the wire is. Coming to the infradiaphragmatic, so the same variants can happen in the infradiaphragmatic, that is the IVC variants. The commonest variant that you come across is a duplicated IVC. So duplicated IVC, it could be complete, it could be partial. So keep an eye. So if it's a complete, majority of the time, the left-sided IVC drains into the left renal vein. Sometimes it's continuous without any joining as an ajagus continuation or hemiajagus continuation. So you should be aware, like, this is something like it's not abnormal, it's just a variant anatomy. This is another scenario where, if you can clearly see, this case, like this is a partially duplicated superior to the left renal vein. Up to the renal vein, there is a duplicated. Then above the renal vein, there is another duplication of the IVC. Likewise, sometimes the left IVC is partially duplicated. This here you can see, this is a very rare, and it's continuing as a left renal vein. There's no continuation beyond this one. So you should be aware of all these things. Until now, we talked about what is the normal anatomy, then what is the variant anatomy. Then come across the acquired abnormality of venous anatomy. One of the commonest scenarios you come across, especially the Indian continent, when people have catheters for long term, over the time what happens is the veins become thrombosed, become occluded, or become stenotic, and then you start developing collaterals. So you should be having a close eye on this one to see, is this acquired or is it something else? So sometimes you have occlusions. That means there's no connection from the outside vein to the central veins. This is commonly used in SVC occlusions or brachiocephalic veins. So this is where comes central venous occlusion. So we can call this as a disrupted venous anatomy. The initial phases of this occlusion, what happens is body acclimatizes. So when the moment there is some trauma to the blood vessel, it narrows, and the sister blood vessels that we call as collaterals, they start opening up. This is where you see a lot of collaterals. Sometimes these are very obvious on the chest. Sometimes they are not obvious until you go into the body. So this is a stenotic blood vessels. And this is another scenario just demonstrating. See, IJV is the commonest vein that you come across. EJV, which is an external jugular vein, which is next to the IJV, in a normal person with no increased atrial pressure, you won't see this prominent. You see this prominent when there is some narrowing in the other blood vessels. So you should be keeping if you see an EJV as a prominent, the first thing you should be thinking, is there any narrowing in the central veins? Occluded SVC. When you have occluded SVC, body changes its shape by forming collaterals and by like demonstrating other venous hypertension picture. So the first and commonest thing it will enlarge is the ajax vein becomes very prominent. Sometimes you see internal mammary vein has become a prominent one. So this is another scenario where there's no central veins at all. As you can see on the left side here, all the patient is surviving is because of some collaterals. It could be intercostal veins. It could be other tiny veins which you never thought this could become so prominent. So this is the case where you see a lot of intercostal veins draining into the central veins. There's no central veins in this patient. So the other commonest scenarios you come across is occluded brachiocephalic veins. So on the left side, as you can see, there is no brachiocephalic veins. There's no SVC in this patient. Likewise, the same thing, scenarios you can see in the infradiaphragmatic IVC occlusions. So they all start with occlusions, thrombosis, stenosis, collaterals, and finally there's nothing left in the infradiaphragmatic. So as you can see in this picture, the second and third one is completely occluded. So this patient has a chronic IVC filter which is thrombosed, everything has been collateralized. Here, there's no patent IVC, it's all been collateralized by the ajax system and hemiajax system. Out of all this, sometimes you come across young patients having some issues with the venous anatomy. So keep an eye in these patients. Sometimes there's something called thoracic outlet syndrome, where the rib or the first rib or the an extra bone might be compressing on the venous system. So these patients might benefit from surgical resection. The other thing you should always be aware is some complications which can happen and which can disrupt the anatomy. This is a picture which is showing the catheter appears to be in a perfect place, but when you aspirate blood, no blood has been drawn. This catheter, if it's been manipulated, suddenly the patient collapses on the table. This is because somebody has placed the catheter into the pericardium, which is completely dangerous situations here. The other thing is you should always be aware, the anatomy, how the wire traverses and everything. When your catheters are not traveling in the direction you want, always remember, if this is not an variant anatomy, is this a complication of your procedure? So it's an example of this one is if you do a lateral x-ray on the chest x-ray, instead of the catheter going straight in the center, it's going way posterior. So because of the experience I can tell, this catheter is in the pleura, it's not in the venous system. So blood is not aspirated, the catheter is not right place, so you should be aware, okay, this is somewhere else. On the left side one picture you see, this was placed by anesthesiologist during an intra-procedural as a subclavian catheter. This is where we always say beware of subclavian complications. So it resulted in a hemo and pneumothorax, and they were not aware until the end of the procedure, so we have to go in and put a chest tube for this patient. The other commonest scenario when you don't use ultrasound or fluoroscopy. So in simple terms, what we say is right side catheter placement, your wire should never cross the midline to the left side. Likewise, left side catheter placement, your wire should never cross more than needed on the right side. So this is an example if you closely look, the catheter is being placed on the right side. I'm not sure what vein they accessed, but the catheter is placed into the mediastinum, and the blood was not aspirated, and when they took the chest x-ray, this is how it looks. So this is a dangerous situation. You don't know whether you went through the heart, you went through the blood vessels, or you went into the mediastinum. So in a nutshell, venous anatomy is the basic steps which is needed for placing a hemodialysis catheter. It's for safe access. Even for any skillful placement of this catheter, you should have a basic understanding of the venous anatomy.